We're live. Thanks.
Hi, for everyone that's joining us, we're going to give it just a minute for everyone to come in. We'll be started in just a couple of minutes. Wish we had some holding music.
No.
We're going to give it just a few minutes, everybody. We're waiting for everyone to join the call.
A little Earth, Wind, and Fire, a little Stevie Wonder in the background.
Like that. Yeah, that's the vibe I'm thinking about. Yeah, for sure. I was born in September, so I love it.
Yeah.
All right, I'm going to go ahead and then get started as we allow for some more people to join the call. But I'd like to say good afternoon to everybody. My name is Akil Hunt. I'm the Director of Patient Empowerment at Travere Therapeutics. Travere is extremely proud to once again sponsor the Black Health Matters Health Summit. We believe in BHM's mission of driving health equity for all communities. We champion all of the speakers and contributors that have participated here today. We encourage everyone to please visit the Travere sponsored section of the BHM virtual booth if you have any other additional questions or looking for more information after the program. As we begin, I'm happy to introduce this afternoon's speaker, Dr. Keisha Gibson. Dr. Gibson is Associate Professor of Medicine and Pediatrics and Chief Pediatric Nephrology in the Division of Nephrology and Hypertension at the University of North Carolina at Chapel Hill. She is also the inaugural Vice Chair of Diversity and Inclusion for the Department of Medicine. Dr. Gibson received her medical degree and Master's of Public Health degree in epidemiology from UNC Chapel Hill. She completed a residency in general pediatrics at Medical University of South Carolina in Charleston and a clinical fellowship in pediatric nephrology from UNC Chapel Hill. She is board certified in pediatrics and pediatric nephrology. Dr. Gibson has been recognized with numerous honors. In 2018, she received the Hyman Battle Distinguished Excellence in Teaching Award, and in 2019 was awarded the Foundation Phase Excellence in Teaching Award. On the national stage, she is currently serving as Secretary Treasurer of the American Society of Nephrology and as Nephrology Counselor for the Society of Pediatric Research. Dr. Gibson is originally from Durham, North Carolina, and graduated from Jordan High School. And if my research is correct, I believe it's home of the Falcons. She studied molecular biology at Winston-Salem State University, go HBCUs, and before earning her medical degree at the University of North Carolina School of Medicine. Without further ado, I'd like to turn it over to Dr. Keisha Gibson. Dr. Gibson, hi, how are you?
I'm good this morning, Akil. Thank you so much for that gracious introduction. I first just want to say thank you to the organizers of Black Health Matters Symposium for this invitation to come address everybody today. This is a topic that's near and dear to my heart. I want to thank all of you for taking time out of your day to join the symposium today, to take charge of your health and to engage on this moment of information. So I often tell people that I'm not an accidental nephrologist. I grew up like many people in African-American families with lots of people that were affected by kidney disease. And so this is more than a career for me. This really is my passion and something that is really dear to my heart and provides me a way to really serve my community. So we're going to talk a little bit about kidney disease today. So if I can get my slides to advance, here we go. So kidneys, why are we focusing on this today? Well, your kidneys are some very busy organs in the body, and often we tend to not pay as much attention to them as we should until they're not working well for us. So your kidneys are found really towards your back in the space that we call the retroperitoneal space. And many of us on this call will recognize that one of the primary functions of your kidney is to filter blood and remove waste. But your kidneys do a lot more than just that. They really function as a center of hormone development. So they secrete hormones that help regulate your blood pressure. They do this by regulating electrolytes like sodium, and tells your body how much water to let go of and how much to hold on to. It sends out hormones that tell your bone marrow to make red blood cells to prevent anemia. In children, your kidneys are very important for the function of growth hormone. Some of you on this call may remember Gary Coleman from the 1970s and 80s, and remember that he had very short stature. He was somebody that was affected by kidney disease as a child. Your kidneys are responsible for changing vitamin D. So the vitamin D that you get from food and the vitamin D that you absorb from the sun has to be activated to a form that your body can actually use to reabsorb calcium. And so if you have kidney failure, you can't change vitamin D to an active form. So this really has an impact on your bone health. So your kidneys really do a lot more than just filter waste products. And they're working hard. So over the course of the day, your kidneys will filter 120 to 150 quarts of blood. That's just under 150 liters of blood per day. And so in any given minute, going through the filters of your kidney is about the same amount of volume that you would find in a can of soda. And so you can imagine if your kidneys are, if your kidney filters are blocked with scar, blood can't get through there and you're losing function, you can imagine the impact that it has on your overall health and how that would really impair the ability to clear toxins and waste products from the blood. There are currently 37 million people right now living in the United States with kidney disease. That's a huge number, 37 million. And if you look at our Black population, where we only represent about 13% of the population, we represent over a third of the patients that are currently on dialysis. So Black Americans right now are 4 times as likely as white Americans to develop end-stage kidney disease. This is a public health emergency and nothing less than that. So while we recognize that poorly controlled diabetes and hypertension is a major contributing factor for kidney disease in the African American population, there's a growing understanding of another disease process that explains some of the excess burden in our community. So I'm going to pivot a little bit and talk about something called nephrotic syndrome. Now, nephrotic syndrome really covers a collection of symptoms, and in and of itself is a symptom. So if I give you somebody with a cough, that cough is a symptom of something else, and it could represent somebody with asthma. A cough can mean that you have a cold. It can mean that you have acid reflux. Nephrotic syndrome is a symptom of kidney damage, and it is characterized by this disease where you're spilling a lot of protein in the urine, where you have high cholesterol in the bloodstream, and oftentimes you have some swelling. Now, there are lots of different causes of nephrotic syndrome. So again, just like that cough can represent multiple things, nephrotic syndrome can be a symptom of different kidney diseases. And usually blood tests and a kidney biopsy is necessary to help us figure out what the actual cause is. And one very important cause that we're going to talk about that we're understanding a lot more, especially in the Black population, is a disease called focal segmental glomerulosclerosis, or FSGS. So what is FSGS? If I were to do a kidney biopsy, and when I mention kidney biopsy, we're not really talking about an operation where you get a large incision and then cut out a wedge. We typically do what we call a needle biopsy. So this is usually an outpatient procedure where we have a spring-loaded needle that goes into, because remember I said the kidneys kind of sit in the back, and using that procedure, we're able to collect some kidney tissue that we can look at under the microscope and stain it and try to help us differentiate certain diseases. So if I were to do a kidney biopsy and pull out a few of those kidney filters that we call glomeruli, FSGS really stands for the injury pattern. So that means that some focal, so some of the filters in a small section, so not the whole filter, but in a segment of the filter, has scar. And glomerular relates to the filter, and the sclerosis is scar. So some of the filters have a segment that is filled with scar. So if these filters are now filled with scar, you can see over a period of time that blood can't get through and it can cause kidney failure. But we're going to look at this on a little bit more of a closer level. So if I were to take your kidney and pull out one of these filters that we mentioned, which is the glomerulus, and look at how the glomerulus is built, there's a little bit of a wall around there that we call the basement membrane. And on the other side of that wall are these specialized cells called podocytes. Those podocytes are very important because they make up the integrity of that wall around the filter, around the glomerulus. And if there's anything that injures those podocytes, they now lose their integrity. They become somewhat flattened out and stretched out. And now as blood is coming through those filters, things like protein and blood cells can leak through that should normally not leak through into the urinary space. And this is a bit of a closer picture. See if I can find my pointer here. So if we were to imagine that this was somebody took the filter and just kind of flattened it out. On this side, blood is coming through. This is that wall that I talked about, the basement membrane. And these are those podocytes, those special cells. Well, if you have something that damages those cells, they've now lost their integrity. So as blood is coming through, those proteins that should stay in the blood space are now free to leak out into the urinary space. And this is what we can see with anything that causes nephrotic syndrome. And this is just another look at that. So blood comes in, and you can see basically these capillaries, the filter that we talked about, these tiny little holes, but what you can't see is sort of hugging these capillaries are those podocytes. And so in patients that have FSGS, over a period of time, they actually develop these segmental scars. And again, as you can see, blood really can't get through these areas. So what are the symptoms of FSGS? So if we have protein leaking out into the urine, what does that mean for a patient? Well, you may notice some foamy urine. So when you go to the bathroom, the urine may take on the appearance of like beer, if you can imagine like the foam top of a beer. One of the proteins that people leak into the urine is a very special protein called albumin. And it is a large protein that should stay inside the blood vessel space and work like a sponge. And so now with FSGS or other syndromes that cause nephrotic syndrome, if I'm spilling all of these sponges out into my urine and I don't have enough inside my blood vessel space, fluid doesn't stay inside the blood vessels and can leak outside. And so that fluid leaks outside the blood vessel space into fat tissues, into other spaces like your abdomen, your lungs, and you become swollen. So people with nephrotic syndrome, in addition to finding foamy urine, will also find swelling in different parts of the body. When we do blood tests, as physicians, what we'll find is that your blood proteins are pretty low. So you'll have low blood albumin. And because now you've wasted lots of different proteins, your liver is working really hard to replace the proteins that are leaking out in your urine. So it's all revved up. But your liver really can't turn on the factory to make one thing. So now the liver is revved up trying to replace all these proteins you're losing, but it's also revved up making cholesterol, because that's a large part of where your cholesterol comes from, is what your liver actually makes. So patients with nephrotic syndrome will have low blood protein levels, so low albumin levels. They'll have high cholesterol. And over a period of time, as disease progresses and you develop more and more scars in the kidney, and there are more areas of the kidney that aren't getting good blood flow, you'll start to see a decrease in kidney function. And the way that we estimate your kidney function is by measuring something in the blood called creatinine. So creatinine comes from your muscles. Your kidneys are supposed to filter it. If you have kidney failure, if your kidneys aren't working well, then creatinine builds up in the bloodstream. And so a higher creatinine level would signify lower function. And again, remember I told you the kidneys are busy. It's one of the hardest working organs in the neighborhood. And so in addition to it really being there to help filter waste products, Your kidneys are also important for regulating blood pressure, and people with kidney failure lose their ability to truly regulate their blood pressure. So your kidneys spit out hormones that cause your blood vessels to tighten, so tighten down, so that increases the pressure or makes you hold on to extra salt and water. So all of these could be symptoms of FSGS, which is a very common cause of nephrotic syndrome. So again, so how do we diagnose FSGS? Well, it's really going to come down to the kidney biopsy. We're looking for that pattern of injury where some of the glomeruli, which are the filters, are filled with scar. And we're going to do blood and urine tests to see, do you have a lot of protein in your urine? Are your blood protein levels running low? Do you have high cholesterol? All of these are factors that go into our picture for diagnosing FSGS. An additional thing that you may or may not discuss with your physicians is that we're starting to do more and more genetic testing. So we can use blood to look at genetic tests to see if there are mutations that we understand or that we know about that could also help us to find a diagnosis. So who is being impacted by FSGS? Well, there's a reason why we're talking about this today during this summit. FSGS is now the most common cause of glomerular end-stage disease in the United States. So this is rivaling, it's coming close to diabetes. FSGS accounts for 20% of nephrotic syndrome in children and 40% of nephrotic syndrome in adults. So even as a pediatric nephrologist, I am taking care of a lot of children that are developing this disease. Globally, it affects 8 in a million adults and 1 in a million children per year. And very important to this audience, is more common in people of recent African ancestry. And we're going to talk a little bit about what we're learning to help us understand why this seems to be the case. This is touching a lot of homes. So many of you may recognize two of these basketball players, Alonzo Mourning and Sean Elliott, both of whom developed end-stage kidney disease due to FSGS and required a kidney transplant. So this is a disease that does not discriminate based upon who you are. And so just as we've discussed that nephrotic syndrome is a symptom and it can be caused by multiple different things, FSGS is a disease, but what we're describing is an injury pattern on the biopsy. So we do the biopsy, we see the scarring pattern, and we call it FSGS. But I think of this as almost like a skid mark in the road. When you see a skid mark in the road, you don't know if that was a Toyota, you don't know if it was a Honda, you don't know if it was a BMW that caused that skid mark in the road. And so FSGS is very similar. We see the injury, but the question is, what is the primary cause? And so there are several different baskets or types, if you will, of FSGS that we look for. So probably the most common is this basket term, idiopathic or primary FSGS. The running joke is that idiopathic means the doctors are idiots and we haven't figured it out yet. But we come to this diagnosis by making sure that we're not missing secondary causes. So we understand that there are several mutations, there are several genes that can absolutely cause FSGS. Most of these genes are genes that impact the podocytes. So remember those very specialized cells that sit around the membrane of the glomeruli, around the membrane of the filter. And those genes can lead to FSGS. I will tell you that in 2005, we had like a small handful of genes that we knew. We're now up to more than 50, and that list is growing. So there's probably more that are out there, and we don't know about them yet. So even if you get a genetic test done and we don't identify a genetic cause, doesn't mean that there isn't one there. It just may not be something that we've discovered yet. And then another big basket of called secondary FSGS. So it has been very well described that there are some viruses that are highly associated with FSGS and we think actually do cause FSGS. So in patients that have uncontrolled HIV disease, FSGS is a common injury pattern that we see on the biopsy. There's another common childhood disease that we have called parvo that sometimes we'll see this associated with. There's certain medications that have been associated with this, in particular, some chemotherapies that may be associated with FSGS. There's certain types of cancers that in and even of themselves can cause FSGS and nephrotic syndrome. Usually, if we can treat the cancer, we can treat the kidney disease. Likewise as well for HIV-induced FSGS. If we get HIV under control, we can often get the kidney disease under control. Individuals that have lost a kidney for some reason, either were born without a kidney and they now have an additional hit, either they've gained too much weight too quickly or have been exposed to medications that are harmful, we can see secondary FSGS. So all of these are things that by the way of secondary injury can cause FSGS. So we're trying to understand why is it that we see an excess burden of FSGS in Black Americans and honestly individuals of African ancestry globally. And about 10 years ago, there's this gene called APOL1 that sort of came to the forefront. We started to learn more about. So APOL1 actually encodes a lipoprotein that is important for helping to protect people from a very resistant strain of trypanosomes. So those are the organisms that cause African sleeping sickness. And it has been found that if in endemic areas, that if you're somebody that does not carry one of two mutations, we call it G1 and G2 mutations, if you don't carry either of those, then you have a high likelihood of dying from contracting this resistant strain of trypanosome. If you're somebody who has one copy of this mutation, then you're protected from dying from that trypanosome, and you don't have an increased risk of kidney disease. But if you're somebody who actually carries two copies of these mutations, then you're protected from dying from trypanosomes, but there's this 2 to 4-fold increased risk for developing chronic kidney disease. And what we know from studies here in the US and in other countries is that 12 to 15% of African Americans actually carry two copies of this risk allele. And so it's something that's been conserved generation to generation. So about 1 in 5 Black Americans carry two copies of this risk allele. Now, it does not mean that 1 in 5 people carry this risk allele and may develop kidney disease. So this is very important to hear. Even if you have two copies of this risk allele, it doesn't necessarily mean that you're going to have kidney disease. 1 in 5, there's a 1 in 5 chance that you will develop kidney disease. So this is a very important distinction and why it's important to have the conversation with your physician about what this actually means for you. We find that this high-risk genotype actually accounts for about 70% of the non-diabetic kidney failure that we find in African Americans. So this is absolutely huge. And about 4 in 10 African Americans that are currently on dialysis do carry two copies of this risk allele. And as a pediatric nephrologist, this is very close to my heart to understand because this is a disease that presents early in life. And so individuals that have this, what we call high-risk genotype, so two copies of this mutation, the disease onset tends to be much earlier in life. So even as young as 15 and 16 and 17 years of age, we're starting to see evidence of kidney disease early. This is a study that was published from the American College of Cardiology. And they found that individuals that either had individuals that had two copies of this risk allele had much higher blood pressure, and the onset of hypertension happened at a much younger age of onset. So again, this is a disease that seems to present itself earlier in life. So how do we treat FSGS? Well, currently there are no medications approved specifically to treat FSGS. Everything that we do is supportive. So we want to take control of the things we get to control. So we can control blood pressure because we know uncontrolled hypertension will cause kidney damage. So we take control of that. And then we're thoughtful about what we choose to control blood pressure. So a very specific class of blood pressure medicines called ACE inhibitors and angiotensin receptor blockers are very important to employ early in the disease. So in addition to helping blood vessels relax, this medication on a molecular level actually blocks some of the processes that have to happen to make a scar in the kidney. So this really helps to slow the progression of the disease. And so when you hear that, right now we're dependent on supportive care, that should raise a red flag that, this is an area that we really need research. We really need to develop novel drugs to really actually treat the disease rather than put a Band-Aid on it. And so just very quickly, I just want to remind, I think we're hearing a lot about clinical trials, especially with what all of us are very sensitive to with the development of vaccines, is that research studies go through phases. And so when we're thinking about phase 1 clinical trials, that's when a company has a candidate drug. We want to know what the side effects are. So this is a very small study specifically looking at side effects. And then once we determine that it's safe to do on a larger level, we move to a phase 2 trial, where again, we're assessing for safety first and foremost, but we really want to know, does the drug work? So we're looking at efficacy and safety. And then when, if there are good positive results from phase 2, then we move into much larger phase 3 trials. One, to make sure that we can compare it to what's out there. So is this drug better than standard of care? And in this case, for FSGS, it would be supportive care. And also, is it generalizable? Would we use it in much larger cohorts of individuals? In thinking about clinical trials, and this is very important because we actually now do have at least one ongoing clinical trial for a candidate drug for FSGS, for APOL1, mediated FSGS, is to talk to your physician about whether or not this is a safe and good thing for you to do. One, do you qualify for the study? And two, understanding what the participation would mean for you. Shared decision-making is important across the board. You should feel comfortable in being able to talk to anybody about your disease. You should know what it is, understand what we understand about how it came to be and what you need to control it. And if medications are being recommended to you, always feel empowered to ask questions and make sure that people are explaining to you why you're taking the medication, what are the side effects, what are my alternatives. You always want to feel empowered to make sure that you're getting all of those answers. Definitely encourage you, as you heard from Akil earlier, we do have a booth if you're interested in coming by to get more information. These are all wonderful resources to find good, solid information and to help connect you with additional resources if you need. And with that, I'm gonna stop sharing my screen. Actually, I think I can leave my screen up so that I can go to questions.
Yeah, Dr. Gibson, we have a few questions already. And for those of you out there that have some additional questions, please don't hesitate to put them in the Q&A section down below. First thing, Dr. Gibson, someone wrote in, said that they have a friend who is in renal stage 3B. What can I do to empower and assist him in giving him facts? He's fearful after visiting the nephrologist recently.
Yeah, so that is a very good question. I find that often, we get paralyzed in our fear from getting information that could help us to stay where we are. So hearing stage 3 kidney disease, I would really encourage your friend to think of it as, I have an opportunity. I have an opportunity right now, and I need the information that I can use to make sure that I stay at a stage 3. If there's an opportunity for improvement, obviously that's what we want to do. But I think that once you've gotten to stage 3B, what you want to hear, what are my options to slow the disease process of whatever is happening? And very importantly, let's say that things are progressing, what are our next steps? Sometimes I think that our fear gets out of control because we don't have the information and we build things in our head and it just paralyzes us from, taking charge of the things that we can take charge of. So now's the time to start having those discussions. Okay, if I progress, What are my opportunities for a preemptive transplant if that's where we're headed? What are my treatment options? Are there clinical trials that are available that might be able to help me?
Okay. We have a couple of questions about herbs and I guess non-medication therapies that can be used, and then the role of medication. Does everyone have to go on medicine, or are there other alternatives?
That's a great question. So, I can't put everybody in one basket because there's so many different kidney diseases that are out there. So this is where it's really important to partner with your physician and make sure that you are being very open and honest about anything and everything that you're taking. Sometimes I think that we don't give appropriate, not credit, but respect for herbal therapies. In our mind, we're thinking they're natural, they're herbal therapies. They are drugs. They are just less manipulated drugs. Anything you put in your mouth, anything you put in your body is going to alter the chemistry. And so we really want to be mindful of what the potential downsides are of it. There are some natural things that you can do. I do talk to patients about trying to steer towards more of a plant-based diet. There's a good colleague of mine in Texas, Dr. Weston, who's researched the impact of a high protein diet, of a high animal protein diet on kidneys. And we do find that those high acid diets may impact or speed up kidney disease progression. So steering towards more of a plant-based diet, if you will, can certainly be helpful. But please, please, please do have a lot of respect for herbal therapies because they are drugs too.
Great. There's another question here about, can you explain some of the differences between diabetes and kidney disease? Their family has a history of diabetes. Is kidney disease something they should also be concerned about?
Yes, no, great question. So diabetes and kidney disease do not have to go together. So diabetes is just your body's inability to process sugar the way it should. And so if you have diabetes and you're not controlling it well, those high sugar levels cause inflammation in the filters of your kidney and can lead to irreversible kidney damage. But if you have diabetes and you're keeping it well controlled, that will prevent you from developing kidney disease. So you hear us talk a lot about diabetes and kidney disease together, but it's because, we have patients that, do not have good control of their disease. And so we do see a lot of kidney failure related to diabetes, but they don't have to be tied together.
Okay. A few questions here around diet. Do you have any specific diet recommendations? Is keto diet bad or good for your kidneys? Are there any specific foods to stay away from? You talked about high acidic protein, but are there any specific things to stay away from, or anything that might be better for the kidneys?
That's a great question. So, and in particular in Black Americans, we have a lot of hypertension in our community. And so, trying to focus on a low sodium diet, I think one of the best diets, I think, for sort of good preventative, for good health, promoting good health, is the DASH diet and the Mediterranean diet. They tend to be lower in sodium. You're taking in good proteins. And so I think from a kidney health standpoint, that's going to be your best option. I would be cautious with the keto diet, is not to say that it's a bad thing. There are some situations where a keto diet may be good for short-term goals. Again, partnering with your doctor. But it does tend to be a very dehydrating diet. And people tend to consume a lot of animal protein when they're on keto diets and high saturated fats. And so it's not really, the keto diet is not something that I would recommend for sort of a long-term, diet plan, but certainly steer more towards the DASH diet, Mediterranean diet. I think for long-term health, those are some of the best options to go for.
Okay. Is it appropriate to ask your provider to check for the probability of kidney disease when your BP is controlled or uncontrolled and no other factor seems to exist or obvious?
Oh, that's a great question. Kidney disease is sneaky. It is so sneaky. And so I really encourage everybody on this call, when you're going in for your annual checkup, you need to know what your blood pressure is. You need to know that you have screened negative for diabetes, and you need to say, hey, doc, how's my kidneys? You know, we want to get your kidney function measured. Kidney disease often can be symptomless until you've actually gotten to more advanced stages. And so if you want to capture things early in the process where you have an opportunity to preserve your kidney function, you want to catch it early. So you have to do this by making sure that you know your numbers.
Next question is about COVID-19. Can you talk about COVID-19? Can it somehow potentially induce kidney disease? And what are factors I should look out for if I have kidney disease in regards to COVID?
That's a great question. So we have been very concerned about COVID-19 and what that may mean for us in terms of chronic kidney disease for a good segment of our population down the road. So 25% of people that get hospitalized, and I'm talking about adults, 25% of adults that get hospitalized with COVID-19 develop acute kidney injury. A lot of that disease can be reversible. If they recover, the expectation is that they can recover a lot of that function, but that injury likely leaves behind some chronic damage that's irreversible. And we have yet realized the full extent of what that's going to look like. So we are very concerned about this. This is something that we're definitely tracking. But if you are somebody that has kidney disease, first of all of us should be trying to avoid COVID. Hope you're masking, continue to social distance, even once you get your vaccine, when you're eligible and you have access. But even once you have your vaccine, we still need to employ those, wearing your mask, social distancing, washing our hands, still have to do it. And especially if you're somebody that already has underlying kidney disease.
Great question here. What should we look for on our blood work results to understand if we are within a healthy range of kidney function?
Yes, a great question. So with your blood work, there should be something that says serum creatinine. Right now, that is sort of our standard for helping to estimate your kidney functions. Creatinine comes from the blood, it's filtered through the kidneys. And so there is a range, but the range may vary based upon your body habitus. So if you're a very small, petite woman, you know, a creatinine of 0.5 may be totally normal for you. It's probably normal for you. A creatinine of 1 is probably not terribly normal for you. If you're, you know, a 6'4" muscular man, then a creatinine of 1.2 may be normal for you, but it won't be normal for you if you're an 80-year-old petite, you know, woman. So you really have to have that conversation with your doctor to see what that means. We plug the creatinine into a formula that spits out something called a GFR. Many of you may see in the media that our community, the nephrology community, is going back to look at these clinical algorithms because there has been a correction factor based upon race added to the formula. And so that is all being reevaluated. So you want to talk to your doctor and ask them about if there are 2 numbers for GFR, have that conversation with your physician about what that means for you, is what I would recommend.
A few questions about related conditions and kidney disease, a couple of questions about lupus and kidney disease and how they're related, and a couple of questions about sickle cell and kidney disease.
Okay. And
no, I think people were just asking for how they're related. What
how they're related? How they're related?
Yeah.
Yes, yes. So all of these. So sickle cell. I'll start with lupus. It's one of the areas that I study. So lupus is a systemic disorder. I think of it as an autoimmune disease that affects any organ that has small blood vessels. And guess what? Your kidneys are basically nothing but bags of small blood vessels. And so lupus really can, in several individuals, and in particularly, I think, disproportionately affect Black people, impact the filters of the kidney. It causes inflammation. So there is lupus kidney disease. But you can absolutely have lupus and have no impact on your kidneys. But if you are somebody with lupus, that is an additional part of your health that should be regularly checked every time that you go for your lupus evaluations. Sickle cell disease is a little bit different in that it can cause kidney damage in some individuals. Whenever somebody is in a sickle cell crisis where the small blood vessels are sort of clumped together, they can block blood flow through tiny blood vessels. And in your kidney in particular, in certain areas, you can have what we call a sickle crisis. And so that can cause injury to the kidney. And so yes, sickle cell disease long-term can be also associated with kidney disease. And now that I think care is getting better and better and better for sickle cell patients, and they're living much longer into their 70s and 80s, we're starting to see more evidence of kidney disease that develops over time.
Okay. Just a few more. Keep them coming in, though, everybody. Any suggestions for how parents may help prevent kidney disease in their children? Is a higher intake of water helpful?
Yes, yes, yes. You want to stay hydrated. So I think the important thing for children is helping them to sort of instill good, healthy habits. And I try to keep things very simple for my children. I tell them to help them understand if they're drinking enough water. I force them to look at their pee. I say, when you go to the bathroom to pee, I want you to look. If it's dark yellow, you're not drinking enough water. I want a nice pale yellow urine, and they get that. So that is one way to help them. I talk to them about trying to instill sort of a low sodium diet, but where low sodium for us may mean less than 2,500 milligrams a day. Most young kids aren't going to read the nutrition label before they reach for their French fries. So I talk to them about colors of salt. So I talk to them about white salt, which sits on the table. We're not going to sprinkle that on our food. There's yellow salt, which includes mustard, cheese, French fries, potato chips. The more yellow the cheese, the more salt content. There's red salt, which is hot sauce and ketchup. Brown salt, which is bacon, hot dogs, hamburgers, soy sauce, miso soup. Those blasted little ramen noodles when I lived off of when I was a broke college student. There's green salt, which are dill pickles. And so I tell them that, anytime they're sitting down to eat, I want them to think about a couple of colors of salt they can pull off their table. So if they got to go to Burger King, guess what? They say you can have it your way. Then your way is, if you got to have a cheeseburger in your life, tell them to hold the pickles, the ketchup, and the mustard. You've eliminated 3 sources of salt. If you've got to have French fries, tell them to make you a hot batch. Don't dip it in red salt and don't sprinkle white salt on it. You've eliminated a couple of sources of salt. So I try to meet them where they are. I prefer them not to go to Burger King, of course, but we have to meet everybody where they are.
Great. There were a couple of questions about the role of dialysis. If you can kind of speak to that. Does everyone eventually need dialysis, or can you talk about the role of dialysis folks and some expectations if they have to go on dialysis?
Yeah, it's a great question. So dialysis is what we call kidney replacement therapy. And I really dislike that term because it makes it seem like we're truly replacing the kidneys. Dialysis can really only replace about 5% of what a kidney can do. So the people that go on dialysis are those that have such severe kidney failure that their kidneys are not even able to do 5 to 10% of what we need them to do. And people going to dialysis for different reasons. Sometimes they're just not making water. And so we need to do dialysis so we can get rid of extra water. Sometimes they're not clearing certain waste products like potassium. And those levels, if they get really high, can stop the heart. For children, I end up starting dialysis when I see that they're losing weight and they're not able to grow, and other indications. So we would love for nobody to ever go on dialysis. I think that's all of our goal in nephrology, is for nobody to ever have to go on dialysis. And so this is why it's really important to make sure that we're keeping track of where your kidney function is. We all lose a little kidney function as we age. That's part of the normal aging process. And so if you are 99 and you have stage 3 chronic kidney disease, great, wonderful. That is still more kidney function than you need to feel normal. But we certainly, if you're in your 40s and you have stage 3 kidney disease, we've got to take action. Right now is the time to ask those questions. What can I do now to really slow this process?
So thinking about what someone can do now, there's a question: do you recommend drinking detox tea to help with healthy kidneys and with your urinary system?
I'm not opposed to it, but I don't have any data to tell me that it's helpful. I just water. I want you to stay nice and hydrated. I want you to avoid caffeine. because caffeine actually dehydrates you. And so again, I try to meet my patients where they are. And I understand some people just have to have their Starbucks in the morning to get going. I'm like, okay, that's fine. But guess what? You don't get to include that in your count of fluid intake for the day. So if you're going to have your coffee, make sure that you're matching that with a half a liter of water. Just make sure that you're counteracting what you're losing.
Okay, a couple of follow-up questions. So there were a few people really liked your examples on how to cut out salt. There's a question specifically about pink salt, Himalayan pink salt, and can that be considered a good salt?
That's a great question. It is still salt. So still use it sparingly. It may it has a little less sodium content than your typical ionized salt, but it's still salt.
And another question was, what does GFR stand for? Some
Yes.
people.
Yeah, thank you for that question. So GFR stands for glomerular filtration rate. So your kidney function is 100% dependent upon blood flow going through those filters. And so that's what we're calculating. And a normal GFR is anything that's above 90. And so if your GFR is falling below 90, then that's evidence of kidney disease.
Okay. And there's a couple of questions in terms of, is kidney disease reversible? Are there any things you can do to maybe reverse any progression? If say maybe you had something related to COVID-19 and you've seen kidney damage, how do you know if it's been repaired? Anything along those lines?
No, that's a great question. So with acute kidney injury, so like with COVID-19 per se, people can get better once they are off the ventilator. So we have normal oxygen levels. Their blood pressures are normalized again. They're not being exposed to medications that are hard on the kidneys. There's a chance to recover. So inflammation in the kidney, there's an opportunity to reverse it. And the goal is to try to reverse it before it resorts to scar. So somebody had asked me earlier about lupus disease. Lupus causes inflammation in the filters of the kidney. So when I do a kidney biopsy, if I see there's a lot of inflammation, we're going to be super aggressive in trying to cool that inflammation off as quickly as possible before it heals the scar. Because once those glomeruli get scarred, we cannot reverse that. So if your kidney failure is due to scars in the kidney, that is not reversible. But if there's inflammation, we can reverse it. So that's the reason why I was really focused. If you're somebody, you're being told that you have stage 3 chronic kidney disease, you want to understand, okay, is this all because I have some chronic scarring that I can't reverse? So now what do I do to make sure that I preserve those healthy filters that are still open? Or is there something else happening? Do I need a biopsy to determine if there's a different disease process that requires medications for me to get rid of the inflammation?
Quite a few questions about different liquids and substitutes. So you talked a little bit about water and staying hydrated. Is seltzer water an appropriate substitute? Is coconut water an appropriate substitute? And then some people are asking about decaf coffee versus regular coffee as a substitute.
No, it's all great questions. I think seltzer water is fine. Coconut water is totally fine. These are all very hydrating. They do not have caffeine that's in it. Decaf coffee is probably better than caffeinated coffee for a number of reasons. If you can, reduce the amount of caffeine in your diet, I think that just has some generalized health benefits even outside of the kidney. So I think all of those things are fine. But again, at the end of the day, nothing is going to trump just good old fashioned water.
In addition to that, what are your thoughts on turmeric, black pepper, and or apple cider vinegar on a daily basis to help with kidney health?
Have at it. We don't have any, data to really prove that it will help your kidneys. Certainly won't hurt. And one thing, it'll keep you away from salt. So I would say absolutely have at it. But in terms of good data to tell us, are there direct effects on the kidney? We don't have.
Okay. Let me see. Oh, here's an interesting question. When we say kidney disease, how do we know if it's the left kidney or the right kidney? Is there any difference or?
That's a great question. That's a really good question. So most of the diseases like FSGS that we're talking about today impact both kidneys. And this was a question that we in the medical community had a long time ago. So even before my time, whenever we would do a kidney biopsy, physicians used to biopsy both kidneys. And then they looked up and realized over time that, oh, the data that they were getting from one kidney pretty much matched the other kidney. So for diseases like FSGS and lupus and the things that are more systemic, diabetes, it does impact both kidneys. There are some things that can impact one kidney and not the other. But generally those are related to other things like you have obstruction. You can have, stone disease that only impacts one kidney. Sometimes they're congenital things that you're born with in regards to the drainage system, so the urinary tract of one kidney that may affect that one kidney alone.
And a lot of water questions. So can drinking tap water cause kidney problems? And what are your thoughts on alkaline water and then also cranberry juice?
Oh, great questions. So can tap water hurt your kidneys? Tap water will hurt your kidneys if you say that if you're somebody who's on well water and the water gets infected with heavy metals. And so it's really important that we are paying attention to what's happening in our communities and making sure the water is being tested. I mean, we've all seen what has happened in Flint, Michigan, but lead, mercury, cadmium, those things can actually cause FSGS-like diseases. It can impact the kidney. So we need to really pay attention to what's happening in our communities there. And if you can afford a filter on your water, use a filter. In terms of the other question was about this, cranberry juice.
Cranberry juice.
Cranberry juice is just fine. The benefits of cranberry juice, if you're somebody who has issues with chronic urinary tract infections, there's a component of cranberry juice that can line the coating, the inside of your bladder, and it makes it difficult for bacteria to stick to it. So it may help reduce your urinary tract infections, but it doesn't really have an impact on your kidney.
And then last couple of questions is thoughts on alkaline water, and then at any point, is there a limit to how much water you should be intaking?
Yeah, great question. So I'm definitely not opposed to alkaline water. Again, it's another area that we just don't have a lot of data. I would be cautious. There are some people that are prone to making certain types of kidney stones. And so if you are alkalinizing your urine that way, that may facilitate more kidney stones. So I would be cautious about that. But in terms of it having other negative impacts on the kidney, nothing that I've seen that I would worry about there. And there was a second part to the question that I forgot.
No, is such thing as too much water? Could potentially be a bad thing?
The answer is yes. So I do not want you to go out and drink 3 gallons of water a day because you can overwhelm your kidney's ability to get rid of the excess water, and it can dilute down your blood sodium levels, and that could actually cause brain swelling. So you don't want to overdo it. I think the typical person, I mean, right now we're all inside from COVID. 1 to 2 liters of water a day is a very reasonable target. If you're very active and you're sweating a lot, then yes, you can take it up to 3 or 4 liters. But definitely you can't overdo it. So you want to be careful about that too.
Great. And unfortunately, we're over time, so this is going to be the last question. So, but we really appreciate all the active engagement from everyone. But I think it's a good way to wrap it up. With all the information that you have given today, Dr. Gibson, there's a specific question about why a kidney check is not included or recommended, like colonoscopies or mammograms. And just what are your thoughts on that? And what would you recommend for someone that might be concerned about kidney health?
I think that's a great question. It really should be a recommendation. And I will be honest with you, most people, if you're going for your annual visits and you're over the age of 30, it probably is included. You may not be having a conversation. And I think it's enough opportunity. And there's some areas where I'm sure it's not happening, that is not being measured, and people have to ask for it. This is part of that. When I mentioned kidney disease as a public health emergency, part of the emergency I feel in our community is awareness and making sure that everybody's sort of empowered with the knowledge that this is part of what should be measured. So when you're going in for your physical, you need to know what your blood pressure is. Is it normal? You need to know if you have diabetes or not. You also need to know your kidney function, especially Black Americans. We've got to know this information because we are being disproportionately impacted by this.
Outstanding. So unfortunately, we weren't able to get to all of the questions. I think there's still maybe a couple more outstanding. So please visit the virtual booth to see if maybe you can get some of your questions answered there. But Dr. Gibson, I'd like to thank you so much for taking the time out for answering all of the questions, but also for the presentation here today. I think it's super, super valuable. And there's a lot of folks on the chat thanking you for the informative information.
Thank you. Thank you, everybody, for joining.
Thank you so much, everyone. And this is the end of the session. Thank you so much.